Hi, everyone. Welcome to the Gut Reset Summit. I am your host, Dr. John Dempster, and I'm thrilled to be here with an old friend and colleague, Dr. Peter Osborne. Many of you know him, but he is the clinical director of Origins Healthcare in Sugar Land, Texas, a place where I've been to visit him a couple of times in the past. Very hot right now. He is a doctor of chiropractic, doctor of functional medicine, doctor of pastoral science, and a board-certified clinical nutritionist. And he's often referred to as the gluten-free warrior. And Dr. Osborne is one of the most sought after functional medicine doctors in the country. And his practice is centered around helping those with painful, chronic, degenerative, and autoimmune diseases with a primary focus on gluten sensitivity and food allergies. And he is the founder of the Gluten-Free Society, the author of the bestseller No Grain, No Pain, which is behind me there somewhere, and the host of the Glutenology Masterclass series, The Ultimate Guide on Going Gluten-Free. Peter, thanks so much for being here. It's great to see you again.
Hey, good to see you too. Thanks for having me.
You're very welcome. Well, today we're going to dive into one of these topics that you are very familiar with, and that is gluten and gut inflammation. Before we dive into that, share with us, if you could, just briefly your story, how you got into all of this.
Yeah, I was training, actually. I was doing an internship in the VA hospital in rheumatology. And, it was really a sad situation. A lot of these soldiers would come in, to be put on steroids and drugs like methotrexate, which destroy the gut lining. And it wouldn't get any better. They may have some pain reduction, but they really weren't getting better. And so ultimately their joints were destroyed regardless of the medicine. The whole mantra in rheumatology is take the medicine to preserve your joints. And if you don't take it, you'll be in a wheelchair. Like, fear is a huge selling point in rheumatology, unfortunately. And I didn't never agree with that. I'm like, how can you predict the future? Like, because we see remissions in people, we see spontaneous, and sometimes we see intentional remission through diet change for a lot of folks. And so they would use fear to get these patients to take drugs. And what would happen is once a week, they'd bring the surgeon in and they'd do surgical consult day. And so without even examining the patient, these surgeons would have an x-ray of their joint and say, yep, you're a great candidate for surgery. Let's get it scheduled. And then they'd run them up and do surgery. And they would have failed surgery syndrome, like their joints, because they were already chronically inflamed. They were already chronically broken. They were malnourished. They'd been on these drugs that had destroyed their gut lining for years. And now they wanted to do surgery. And they, when you go under surgery for a joint replacement, there's massive healing that has to happen once the surgery is over. I mean, surgery is scheduled trauma. So these guys, they wouldn't heal post-surgically, or they would heal very poorly, and there would be a lot of complications, right? And then they'd still be on the medications that were driving a lot of the complications post-surgically. So they were so malnourished that they just couldn't recover. And I was like, there's got to be a better way. And when I tried to introduce a better way while I was there, I was kind of spurned. I brought in research on rheumatoid arthritis, and the literature is not a small amount of literature on gluten as a driving force behind rheumatoid arthritis and other arthritic autoimmune conditions like psoriatic arthritis, ankylosing spondylitis, dermatomyositis, fibromyalgia. I mean, these are all kind of the bread and butter, if you will, of what a rheumatologist might see in clinical practice. And gluten plays a role in all of them. And none of these doctors were looking at gluten or asking about gluten or testing for gluten sensitivity. And so I just brought it up and said, why don't we just do a test case? Let's just take 5-10 folks and put them over here in this little mini trial in-house, and let's see if we can get some improvement. And I was laughed at. I was spurned and told no. And then, so I went back to the library and garnered a bunch of research on fasting. I said, look, you don't want to listen about gluten, but what about fasting? Is it 48 hours, a rheumatoid case is pain-free in 48 hours by not eating? That should tell you something. It's not a leap to say that when somebody fasts, they're no longer putting in food that could be potentiating their illness. So nope, they didn't want to do that. And so then I went back again to the drawing board and brought research up on using omega-3 at high doses to mitigate and manage pain. I thought, well, there's prescription fish oil. Maybe we can get some of these doctors to do something for the patient's best interest. Nope, they weren't interested. And there are research studies that show that fish oil is more effective than non-steroidal anti-inflammatories at pain reduction. So I was really kind of, I guess you could say I was green going in and I was cynical coming out. But coming out of the VA, I started my own private practice. I just couldn't work in a system where nobody was thinking, and everybody was just doing what was standard of care, and standard of care sucks. I mean, look at Look at America. I think we rank in the 70s in terms of industrialized countries for healthcare, and we use more medicine than any other country in the world. So how do you put two and two together? Like, more medicine doesn't equate to more health. So in my private practice, one of my first patients was a little girl named Ginger. She was 9, and she was terminal. She had terminal juvenile rheumatoid arthritis. They had given her 6 months to live. Now, her diagnosis came at the age of 2. So for 7 years, from the age of 2 to the age of 7, this little girl was pumped full of methotrexate, which is a cancer drug, which inhibits folate in RNA and DNA synthesis. So basically, it stops people from growing and healing and repairing in the name of pain relief. And she was so much in pain that she had a permanent port embedded in her arm, and she was in and out of the hospital for pain management IV all the time. It was a regular occurrence in her life for 7 years. And then doctors turned to her mom and said, sorry, we're done. Well, there's no more we can do for her. And they just gave up, go home and die. Go home and let your daughter die, was basically what they told her. And so she came to me out of desperation more than anything else, which makes me mad. Like, looking back on it, why should anybody with autoimmune disease come to a doctor like you or me with desperation? Like, we should be the first stop.
Totally.
But no, we're last stop, usually after the medicines failed and destroyed, aspects of their health. And that was Ginger's case. But we tested her for gluten sensitivity. She was positive. Within 6 months, we had the port removed. She no longer needed it. Within a year, she was in full remission. And it was all through diet change. And that's kind of how I got my start into the realm of gluten sensitivity and autoimmunity, was just through that path.
So powerful. Now, listen, I know a lot of people listening have an idea of what gluten is, but let's break it down. What is gluten and where is it found?
The gluten is technically is not a singular term, right? So we say gluten, but it's really glutens because there's more than one. There are different types of glutens found in all grains. So, the predominant, if you look at the standard food labeling laws of, Europe and in the US, it's wheat, barley, and rye, and sometimes oats, depending on who you ask, contain different forms of gluten. For example, wheat has a type of gluten called gliadin. Oats has a type of gluten called avenin. Rye has a type of gluten called cicollinin. They're different glutens in different grains. And again, from a gluten perspective, as it relates to disease, the FDA here in the US says that if a grain or if a food is free of wheat, barley, or rye glutens down to 20 parts per million, then that food could be labeled gluten-free.
Right.
But there's more than just those 3 glutens. Okay, there's gluten in corn called zein. There's gluten in rice called orgenin. There's gluten in millet called panacetin. There's gluten in teff. There's gluten in all grain. And this was my experience in practice. Was I used to think, just like everyone else, let's take a gluten-free. We're going to go wheat, barley, and rye free. And what would happen is they would find the gluten-free food aisle, start pounding rice and corn products labeled gluten-free, and then they would get sick. It was so apparent and so clear that I actually named it gluten-free whiplash, because it was like clockwork. You'd see it 3-4 months into their diet change, and they found all those foods and those substitutes, and just boom, they would go backwards.
Mm-hmm.
And then I stumbled across research, from some really great scientists in South America. They were studying corn glutens because corn is a staple food in South America. And what they were finding is that corn gluten, zein, is actually more reactive to people with celiac disease in many cases than wheat gluten. And they published a number of papers on this. I took that information and ran with it, and we implemented it clinically, and we saw that all those whiplash cases reverted back and started healing again. And so when I wrote my book, No Grain, No Pain, it was very specifically written, no grain, no pain, not no gluten, no pain.
Mm-hmm.
And that's one of the reasons why, is that most people are not aware that all grain, doesn't matter what the label says, all grain contains some form of gluten. And if we define gluten, it is the family of proteins soluble in alcohol found in grains. And they're gliadin, or they're glutelins, which are one type or one aspect. And so there are a number of different families of subfractions of proteins that fit in the gluten category. And so again, there are actually, I think to date, don't quote me on this, but it's somewhere over 500, and I think closer to 1,000 different forms of gluten proteins that have been identified. Researchers in Australia in 2012 found 400 new gluten proteins. I think it was a rather large percentage of those proteins were found to be toxic to those with gluten sensitivity, despite the fact that, again, food labeling laws continue to say wheat, barley, and rye only.
Right.
So again, a lot of people go gluten-free. And I think part of the popularity of keto and carnivore diets is because those diets remove all grain, right? As opposed to a traditional classic gluten-free diet, which is just removing wheat, barley, and rye. And so you see a lot of people going keto or carnivore, and they're finding tremendous help. And I think one of the biggest reasons why is what they're really doing is they're cutting out all gluten from their diet instead of just being kind of selectively gluten-free.
Is there any way to test for these things accurately? Like, I mean, there's lots of tests that are available on the market, but I think there's a lot of downfalls to them, and I'd love to hear what the latest science is showing, because ultimately we're going to want to clear out grains. But is there a way to definitively know if we're reacting to gluten?
Yeah, I mean, there are ways. Let's just say it like that. The problem is when you're dealing with hundreds of different types of gluten proteins, you have to test for them all. So one aspect is if you're not testing for them all, you can miss some, right? And the other aspect is, well, how many different ways can the immune system have a reaction? Well, there's IgG and IgA and IgM and IgE. There's also IgD, which we know less about. There's immune complex responses. There are T cell responses. There are innate immune responses that lead to cytokine storms or cytokine production, all of which would need to be measured. So you'd have to take all these different batteries of different ways the immune system can react, which is a minimum of 6 different ways, right? And arguably more. And then the hundreds of different gluten proteins. So you'd be running, several thousand different types of tests if you were trying to get it accurate. And that's not feasible for most people. You'd spend, over $20,000 in most cases to get that level of testing done. But one of the ways I test people is I do genetic testing. And the reason why there are certain genetic alleles and genetic markers specifically on a gene. There are 2 genes called HLA-DQ genes, but there's an alpha-1 gene and a beta-1 gene. And these 2 genes code for an antenna that sits on the surface of the immune cell receptors. And so what it is, it's an antenna on the surface of the immune cell that tells the immune system what is good versus what is bad, right? That's its job. And so certain genetic patterns will look at gluten and say, that's bad, not good, right? And so that person who has those gene patterns will look at gluten as a foreign invader more than they will look at gluten as a friendly food they can digest and eat. So we do genetic testing to help to determine predisposition to reaction. And if we find a positive outcome or a positive result, then we guide people down a gluten grain-free diet without having to spend, thousands and thousands of dollars trying to isolate the different immune responses in the different gluten proteins.
Awesome. Yeah, that's huge, because again, there's so much misinformation and I think misunderstanding of what we need to be looking for to get a true understanding of how we're reacting to gluten. There's those typical IgG food tests that come back, and if we don't see the gliadin checked off, then oftentimes people are misinformed that they can go ahead and eat those foods. But yeah, that's powerful. So we'll talk about a little bit more of the genetic testing later, I think. But let's dive into the actual gut connection to a gluten inflammatory response. What happens in the gut when you eat gluten?
A lot of things, really. One of the responses is an autoimmune attack against the proteins that seal the gut lining. So there are these specialized proteins that snap the gut cells together, kind of like Lego blocks, right? You got the prong that snaps together, and it's a very tight snap. Well, your gut is snapped together, by these proteins, and gluten dismantles or dislodges these proteins, and so you get a leakiness. And then once you have a leakiness, now gluten and gliadin and other proteins, including bacterial proteins and fungal proteins, things that, from the natural inhabitants of the GI tract. Now all that stuff, instead of being kind of quarantined to the gut lumen, it now gets access. Your poop gets access to your bloodstream through those leaks. And this is one of the hallmarks to why gluten can cause so many different kinds of problems. Because once it rips a microscopic hole in the gut lining, you're just leaking poop and bacteria and fungus byproducts into the bloodstream directly, and a lot of that goes to the liver directly through the portal circulation, and just hammers the liver. So now the liver's under assault. And you take that, you look at the average person above the age of 35 who's on 4 or more medications that are being processed also by the liver, right? Maybe they're gluten sensitive. Their liver's under attack through the leakiness of their GI tract, but then their liver's also under attack because it has to process all these medications that they're taking to cover the symptoms from the leaky gut. And there's no win there. And so the problem just progresses. And then many of these medicines also cause leaky gut. For example, steroids and non-steroidal anti-inflammatories destroy the gut lining. Certain antipsychotic medications, antidepressant medications destroy the gut lining. Antibiotics destroy the gut lining. So, there's a battery of different medicines that very commonly damage the gut lining. And so when you add those two, treat the symptoms of a gluten-related disorder, you kind of now you're getting hit from multiple directions. This is why so many people go to the doctor and they can't get an answer, right? Because the answer is, let's chemically manipulate your symptoms so that you can't feel them, which is akin to turning off the alarm when your house is being robbed, right? That's not something you'd want to do. You'd want to address the criminal one way or the other. And the criminal in this case would be, gluten and the medicines used to treat the symptoms that it induces. But again, ultimately, gluten damages the GI tract lining, leading to an intestinal permeability. And then once it gets access to the bloodstream, now it can go anywhere. There are other aspects to it as well. There's some researchers now showing that it's not just gluten. And I think that's an important component too, because there are other components to grain. There's a family of proteins, for example, called amylase trypsin inhibitors, ATIs for short. They will bind to, there are these special immune receptors in your gut lining called toll-like receptors, TLR receptors. And TLR4 in particular, we know, for example, this amylase trypsin protein will bind to those receptors, creating an inflammatory cascade. So you can get, a non-gluten inflammation that occurs as a result of eating grain as well. So it's not just gluten. It's gluten. It's other what we call sensory plant proteins, which will be like serpinins, purinins, and amylase trypsin inhibitors. These are just plant-based proteins. Lectins, another example. Oxalate, another example of components in plants that, and grains predominantly that can damage the GI tract and lead to these same kinds of symptoms. So this is another reason why a lot of people will get tested for gliadin, as you said a minute ago, but yet their doctor says keep eating it, but then they go on a gluten-free diet and they feel better, right? And it's like, well, I wasn't supposedly reacting to the things. My doctor said my test was negative, but I certainly have recovered my health by changing my diet.
Yeah, it's just one of those things. You just got to take it out. If you've got any chronic inflammatory or autoimmune-based illness, many of the experts that we've all learned from say, look, testing's wonderful, but the best test is to stop eating it. And it's not just for a week either, is it, Peter? You've got to sometimes cut it out for months.
A gluten antibody has a half-life of 90 days. So, that means that takes 90 days for the damaging antibodies to be cut in half. It's not even to get them out of you altogether. That's 90 days just to cut them in half. So, usually it's a bare minimum, of 6 months is what we recommend people start with, no less than that. Now, a lot of people feel better, before 6 months. It doesn't take 6 months to feel better for most.
Mm-hmm.
But because of that half-life, those damaging antibodies can circulate for an extended period of time, and the damage can continue on. And it only, the amount of exposure for somebody who has gluten sensitivity is 20 parts per million. So think about it. 20 parts per million is a breadcrumb, right? It's a drop of water in a gallon of water, and that's enough gluten to cause an inflammatory cascade for up to 3 months. And so you do. If you want to be serious about it and you really want to get an answer, it's best to keep it out for a minimum of 6 months before you come back and say, was this the right move for me? Like, don't
Right.
Go 2 weeks, and if it's not helping, say I give up. You really want to keep it in for 6 months.
And then the other argument that we get often in clinical practice is, well, look, I'm not celiac, so why do I have to avoid gluten? That's what I'd love to hear from you is, what's the difference between celiac and a non-celiac gluten sensitivity? And then maybe we can even dovetail into what's the difference between a sensitivity and intolerance and an allergy. What's going on with all those terms?
Okay, so maybe it's helpful to use an analogy. If I give aspirin to 1,000 people, it's possible some of those people might die. It's possible that some of those people that the aspirin might cause gastric bleeding. It's possible in some cases the bleeding would be so bad as to cause a perforating ulcer. It's possible that some of those people won't react to it at all, and their headaches will be improved or their joint pain will be improved. It's possible that that aspirin will cause iron and folate and vitamin C deficiencies in some. And why do I say all that? Because we're not even talking about aspirin. My point is this. We can give 1,000 people the exact same drug, and we can get various different symptoms or outcomes as a result of administering that exact same chemical to different people. And gluten is no different. You can give gluten to 1,000 people who are gluten sensitive, and some of them may develop celiac disease. It's an estimated 1.4% of the population has celiac disease, but it's an estimated up to 13% of the population has non-celiac gluten sensitivity, meaning they don't develop the same kind of reaction, which is that damage, that villus atrophy damage to the small intestine. Some people get IBS. Some people get Crohn's or ulcerative colitis. Some people, gluten impacts their joints, and so they're suffering with a rheumatological manifestation like rheumatoid arthritis or psoriatic arthritis. Some people are affected in their skin, and so they'll have things like eczema or dermatitis herpetiformis or psoriasis. Some people's livers are affected, and they'll develop autoimmune hepatitis or non-alcoholic fatty liver disease. Some people are going to have low white blood cell counts and anemia. Some people are going to have depression or psychiatric disorders like schizophrenia or bipolar. So it affects different people in different ways. Researchers all over the world have actually isolated some of these different effects and impacts. And one of my, I'll say not mentor, but I watch and read a lot of their work because they do fantastic research. And that's Marius Hadjivassiliou. He's at Oxford in the UK. And they actually call gluten a neurotoxin. And they believe that gluten can manifest solely as neurological damage. There's a condition called cerebellar ataxia, which is, we want to say, okay, what does that really mean? It means you get dizzy and you can't walk very well. That cerebellar ataxia is a gluten-induced disease, right? And some people just develop vertigo and they're like, why am I dizzy all the time? And then their doctor wants to do surgery on their ear, or some other kind of crazy nonsense medications, and they haven't even looked at gluten yet. So gluten, there are about 140 different medical conditions that we know gluten can either cause, contribute to, exacerbate, okay, or play a role in, and not necessarily be the only cause, right? So as an example, neuropathy, gluten can induce neuropathy, but other things can also induce neuropathy. You see what I'm saying? So like it's, I don't want everybody to think gluten is this catch-all for every single disease and only look at gluten. But 140 different conditions, you need to look at gluten and rule it in or out, because it may just save your life.
I guess you make me think of an analogy. If you're trying to put out a house fire, why are you dumping gas on it at the same time? And so it's like, we've got to get to the root of these issues and really look at the inflammation and the source of that. And, a lot of people listening with gut issues right now to this summit, they've got a whole array of different gut issues, but what are some of the top inflammatory gut problems that you see linked to gluten?
Well, definitely. I mean, celiac is the most common, most well studied, but Crohn's, ulcerative colitis, right. I've seen those diseases go into remission, with a gluten-free diet. Gastritis, I've seen people that thought they had H. pylori, were on triple therapy for years. Symptoms didn't go away. Gluten-free diet cured it. I've seen cases of esophagitis where people had EOE, eosinophilic infiltration into their esophagus. Gluten-free diets, I've seen cure that. So, those are all inflammatory, mouth to anus, right? Inflammatory bowel conditions. And there's a whole array of oral conditions, gingivitis, enamel defects on the teeth, creating an increased incidence of cavity or caries formation. So these are, tonsil stones in the back of the throat, where people's tonsils form these white pussy patches in them, and it causes severe bad breath, among other things. It causes the tonsils to frequently swell, and they're chronically dealing with upper respiratory infections and being put on antibiotics repetitively. I've seen gluten make all that go away. So again, these are all just super common things, right? That a lot of people go to their doctor for, but never have a conversation about gluten. As a matter of fact, most people that I see that have inflammatory bowel issues, their GI doctors have said diet doesn't matter. Like, that's a lot of what they hear. Diet doesn't matter. It's not important. I'm like, how's diet not important? It's like, you have an inflammation in your gut. Well, what do you do every day? You put things in your gut. Well, why wouldn't we start looking at what you're putting in, at least as a place to start? But no, for many, it's no, diet has nothing to do with it. And so then they get put on these really powerful, immune suppressing medications that are linked to cancers like lymphoma, right? And that doesn't make sense. So anyway, that I tangented there for a minute, but yeah, a lot of different situations in the GI tract that can manifest as a result of gluten sensitivity.
Is there anybody that really, should never go gluten-free? I think I know the answer, but, is there any contraindications to going gluten-free?
Not really. I mean, the medical argument would be that you're reducing a valid source of dietary fibers and phytates that might have some beneficial effect on reduced risk of colon cancers. Reduced that's pretty much it, because there aren't any nutrients in grain that you can't get in other foods, and you can get fiber in other foods as well. But again, they've done some studies. The fault in the studies that have been done that show that people with going gluten-free have certain nutritional deficiencies. Predominantly, those deficiencies are fiber being one of them. It's because they're eating gluten-free junk food, right? And if they would do a study where they put people on a real food diet and measured nutrition, they probably wouldn't find these same levels of deficiencies. I certainly don't in my practice. When I take somebody gluten grain-free, I don't do it by saying, go buy the cornbread and the rice bread and eat the rice pasta and go drink sorghum-based beers. Like, we take them grain-free. And, generally when we follow up, and I test every 6 months, any of my patients, we test their nutritional status. What we generally tend to see when they first come in, on average, they're minimum 5+ vitamin mineral deficiencies, minimum. And then, after we get their diet dialed in, we come back later down the road and retest. We see that cut in half. Another 6 months goes by. We really see good, solid nutrition. Like, we're not seeing the level of deficiency at all if they keep their diet dialed in. So these other studies where these doctors are saying, well, there's a risk of being malnourished if you go gluten-free, it's nonsense, because they're just, the argument is you can't take people off of gluten and put a bunch of processed food in their diet and expect them to regain their health, because cardinally speaking, you can't get healthy eating food that isn't healthy. So anyway, I think the conundrum in medical science today is largely a lack of understanding just that very thing. Like, just because a food is gluten-free doesn't mean it's good for you, right? Candy corn is gluten-free, technically. Although corn I don't recommend, and corn syrup I don't recommend, but we could make an argument that it's gluten-free, but it isn't going to restore your health if your health is already trashed. So that's really the mistake that a lot of these researchers make when they're doing their study design. They're poorly designed studies, not really shown to show the impact of real food in the ability of a patient to recover from malnutrition.
Yeah, I'm glad you touched on the aspect of the nutrient deficiencies. That we also do the testing with our patients, and we've seen those patterns. And every nutrient has hundreds of responsibilities every second in your body. And if you can have this massive compounding impact if you've got multiple nutrient deficiencies. So I'd love for you to kind of touch on, again, a little bit more of the, maybe indirect isn't the right word, but some of the other downstream sequelae that can happen when gluten irritates that gut lining, like nutrient deficiencies, how it can disturb the microbiome, for example. What are some of the other ways that we should be concerned about?
Yeah, there have been some really good studies that show that gluten affects the populations of Bifidobacter and Lactobacillus. When we test this, these are the two predominant species we'll see people with that history not have adequate quantities of. And so the downstream effects of not having enough bifido or lacto, one, these two microorganisms produce a substance called mucin. Now, mucin is like a mucus that lines the GI tract, and it's like a coating of protection, right? So you don't make that mucin, you wipe out one of the barriers that protects your gut. So it increases the risk for the development of leaky gut. These bacteria also do something very important called immune crosstalk. they talk to your immune system. 70% approximately of your immune system is behind the gut wall. It's got a name. It's called the GALT, the gastro-associated lymphoid tissue. And those cells in the GALT talk to the bacteria and vice versa. It's like the president in the Pentagon. They have a phone, that red line that goes back and forth, right? The nuclear option. Well, they talk to each other about what's happening. And so the bacteria, the good bacteria can warn the immune system, hey, there's something's funny in the gut here. You need to get ready for some stuff, right? And the immune system can say, okay, thank you for letting us know. We've got your back. We're going to make appropriate antibodies and we're going to neutralize this threat. So that immune crosstalk is very important for preventing autoimmune reactions. Then we have these bacteria also produce a substance called short-chain fatty acids, SCFA. One of the primary ones is called butyrate. And butyrate is the fuel source for the colon cells. And a butyrate deficiency has been linked to things like colon cancer. So this is one of the reasons why when we look at gluten cancer associations with gluten, colon cancers are a major association. There's 11 different kinds of cancer we know gluten can increase the risk for, colon cancer being one of them, as a result of this mechanism. And then we also have the fact that these healthy bacteria, some of them make vitamins, different B vitamins and vitamin K. So, we don't just get vitamins from the food that we eat. We also have de novo synthesis from the good bacteria that live inside of us. They can take part of our food and through their own metabolic machinery, pump out different nutrients, and then our guts get to absorb those nutrients. So we want to make sure we're maintaining a good, healthy microbiome. As far as nutrition deficiencies are concerned, I mean, the gambit is true here because gluten causes intestinal inflammation that can lead to reduction of absorption. A hallmark of celiac disease is fat malabsorption. So if you think of fat, what's in fat? Well, there's fat, and some would say, yes, I'm going to lose weight. No, that's not what I mean, really. You malabsorb vitamins that are made from fat: vitamin A, vitamin D, vitamin E, vitamin K, omega-3 fatty acids. These are all fats. And so the capacity to become deficient in fat-soluble vitamins is very, very prolific as a result of gluten-induced intestinal inflammation. But so too are the B vitamins and the minerals, because many of the channels by which we absorb those nutrients are going to be impacted by that gluten-induced inflammation. And so the downstream consequence of vitamins and minerals being deficient, it's endless. How many possibilities we could spend years talking about the different possibilities of what nutritional deficiencies can manifest and how they can manifest and what diseases would manifest or what symptoms would manifest as a result of those things being low. But those are two very, very big ones that gluten contributes to. And then there's another process that, gluten we've seen contribute to, which is a morphine-like process. So when we're breaking gluten proteins down, one of the proteins made is something called gluteomorphin, which behaves like morphine. And this is one of the reasons why when people are under stress, they crave baked goods. They are wanting their morphine fix, right? They're getting their drug hit. It's very addictive. And so it basically increases the potential risk of pain syndromes because morphine interaction with morphine receptors in the brain and nervous system are going to influence the way we perceive pain and the way we perceive the world around us and the way we feel, right? So you have a gluteomorphin impact that is, independent from the nutritional deficiencies, independent from the effects on the microbiome. And I mean, we could go on and on. I don't want to talk all day about that one topic, but there are a lot of different ways that gluten can damage the intestinal tract and the internal microchemistry so as to lead to other consequences.
But I think you just nailed a really critical point, Dr. Peter, is it's akin to almost having a drug withdrawal. And you've got that craving, you've got that drive. And these are powerful urges. And, this is often, and I'm sure you've seen it over the years, that's the resistance that sometimes we have to help educate our patients overcome is like, well, how am I supposed to be able to quit gluten? What do you tell patients? How do you motivate them at that point, other than potentially showing them what can happen, which we've been discussing? But what is your secret sauce to get them off of it?
I don't have one. The way I work and the way I operate is very simple. If your pain levels are greater than your fear of change, then you're ready, then you can work with me.
Yeah.
If I have to try to convince you that changing your diet is something that's smart, then you're not ready for somebody like me. When I work with patients, it's generally there's no convincing. They're in my office because they're out of options.
Yeah.
They're at the end. They've got 5 diagnoses. They're on multiple medications. They don't know what to do. Their life and their quality of life is deteriorated to the point where they're willing to change whatever they need to change in order to get that semblance of reality back, that hope back. So I don't work with people who are dabbling. It's a waste of time. I don't know if your audience or you are religious at all, but there's a passage: "Don't cast pearls before swine." Not everybody's ready to hear this message, and I'm not here to judge those people who aren't ready to hear it. Sometimes we have to get to a point where we're backed in a corner before we're willing to admit we need to do something different, and that's part of human learning, and that's part of our journeys. I'm guilty of it in some regards in different walks of my life, I'm sure, but just there isn't no secret sauce. It's you either want to be healthy and you're motivated to be healthy and make a change, or you're not. And what we do, I guess if you could say there's any secret sauce, it's that we don't just guess, go gluten free. We test, right? So our credo is test, don't guess. So we put in the right types of tests so that we can bring a black and white back to a patient and say, this is you. This is what your body needs. This is what your body is damaged by. Now you have some choices and some thinking to do. But our advice is that you go gluten free, and if you've got other food sensitivities, that you cut those out of your diet. If you've got nutritional deficits, that you add those into your diet. If you've got chemical exposures, that we isolate and identify where those are coming from, and put efforts in place to make sure we're protecting your body from those things so that your body has a platform by which it can restore its health.
Yeah, massive, super powerful. Thank you. Now, listen, we're gluten-free. All right, we're ready to commit. What are some of the other gluten bombs or gluten-free bombs that we need to be looking for and paying attention to?
I guess the biggest is don't read the food labels and trust that the gluten-free on the label is accurate.
Mm-hmm.
That's the biggest bomb. If you can eat whole, real foods that are grain-free, that will protect you the best. But, as an example, you go to the grocery store and there's a gluten-free food aisle, and 90% of the products aren't gluten-free. They're wheat, barley, and rye free. And again, so educating yourself about those nuanced differences is going to be an important part so that you don't bomb yourself or not succeed. There are also foods that can mimic gluten for some people. So, you might want to just be aware of what some of those foods are, because we've seen these foods also create kind of holdups for recovery. Some of them are what are called the pseudo grains: amaranth, quinoa, and buckwheat. Technically grain-free, but their proteins are so similar to gluten that we get cross-reactivity, and so people will react to them. There have been some good studies on quinoa causing inflammatory reactions in celiacs. So, again, a lot of products are quinoa, and not corn or rice, but quinoa, and so that could be a problem for you. Dairy is another big one. Dairy has the potential. The protein, especially the A1 dairies, the alpha-1 casein protein, can look a lot like gluten. So that's another one that can hold a person's progress up if they're still consuming dairy in mass. And then the other one of the other ones that creeps up, that's that you want to, if you're working with a good doctor, ask them to test you for it. If you're not, just be aware. But yeast. Yeast is commonly found in the human GI tract. It's not that yeast is evil per se, but it's the overgrowth, especially of certain species like Candida albicans. Research is showing now that the protein that yeast produces on its cell wall, it's called a hyphal wall protein, can mimic gluten. So people that have gone gluten grain free that still are reacting and can't figure it out, a lot of times these people have yeast overgrowth that has to be dealt with because the yeast is actually producing gluten-like proteins that they're reacting to. So those are some bombs that, if you understand that those exist, you can kind of navigate and hopefully push your way through this and get better.
Yeah, huge. And I suppose another one would be like trying to eat organic as much as you can to avoid herbicides, pesticides, things like that too.
Yeah, I mean, absolutely. Again, going back to can't get healthy eating unhealthy food.
Mm-hmm.
So be honest with yourself. Progress begins with honesty, right? Is a pesticide healthy? I think we could all agree probably not. You wouldn't eat pesticide without food. So why would you eat food with pesticide, right? So, I mean, some people say, well, how does farming work? How do farmers grow enough food? I think that's a big conversation, maybe for another day, but there are plenty of ways to do regenerative agriculture that don't require pesticides and other chemical compounds or genetically modified foods. We could say how safe they are. I mean, industry funds those safety studies, and industries who profits from the sale of those genetically modified or pesticide-laden foods. We could say how safe they are, but in fact, the reality is we can draw a corollary curve that from the introduction of those chemicals, we see an exponential rise in chronic inflammatory degenerative disease. And, many would argue correlation and causation aren't the same thing. I agree. But I would also agree that correlation can't be ignored. And you shouldn't put your head in the sand and say, hey, let's eat all the pesticide we want because good old Uncle Sam or the government, who's captured by industry, tells us that it's good for us, when in fact, most people that are going to end up with cancer or heart disease or diabetes or obesity or some form of inflammatory disease. And if everything is so safe and everything is so healthy, why are all these people so sick?
Fair point, and a massive, massive point to consider. Right, this is a bigger conversation I think to be had there. But Dr. Peter, this has been immensely helpful to anyone who's been listening to this. And as always, you are dropping tons of wisdom and based on your research. So thank you for sharing that. Is there anything else we need to know about gluten and gut health before we sign off today?
I would just say if you've been diagnosed with any form of autoimmune disease, I'll just share my experience. I've seen thousands of cases in 20 plus years of practice. I've never seen a case of someone with autoimmunity where they were not gluten sensitive. If that helps your audience in any way, if you're watching this and you just don't want to spend money, your doctor won't run the test, give the diet a go. Give the diet a go. That's free. It doesn't cost you anything to go gluten-free. It might cost you your life not to. But if you're not sure, give it 6 months. And if you're going to do it right. Don't go gluten-free, but eat all the sugar in the world. Like make a real effort at not just being gluten-free, but also being healthy with your food choices.
Great. That's huge. Dr. Peter Osborne, thank you so much for being on the Gut Reset Summit. I really appreciate everything that you're doing.
Hey, thanks for having me. Pleasure as always.
Have a great day.